Welcome, everyone. My name is Mario Tsokas, and I'm a psychogeriatric resource consultant with the PRC Program of Toronto, and I'm based out of the University Health Network, Toronto Rehab. And joining me today as my co-facilitator is Heliola, who is PRC herself, but she's also the PRC Program of Toronto's program lead, and we support homes in the Toronto area. So just to get started, just for disclosure, we don't have any relationships with any grants or research, any speakers bureau or honor area, and there are no consulting fees as well. And there's, for disclosure, financial support. This program has not received any financial support other than support of the Ministry of Health and Long-Term Care. This program has not received any in-kind support, and there's no potential for conflict of interest. And there's no mitigating potential biases to declare as well. So we are very pleased to be invited by the CLRI to talk about team integration of staff being redeployed into long-term care. That's what we're going to be discussing today. As psychogeriatric resource consultants, we've been redeployed out of long-term care currently, but we've stayed very much in close contact with the long-term care homes that we do support. As we know right now, it's a very unprecedented time in long-term care and in the healthcare system in general. There's been a lot of changes because of the pandemic, and it has had quite an impact on all areas of healthcare, but especially long-term care. And having teams being redeployed into long-term care to support the care of our frail elderly residents has been very helpful through our discussions with our long-term care homes. We're very fortunate that we're still very much in close contact and hearing the feedback from our long-term care homes, because we're hearing about what are the successes of the redeployment, but what are some areas that we can enhance the experience of both the people who are being redeployed into long-term care, but also for the long-term care teams as well. So throughout this presentation, we're going to be talking about salient lessons learned from the experiences of the long-term care home, but also the redeployed teams as well. As PRCs, we're based out of hospitals for the most part, and we hear the experiences from both ends. So just to give you a little bit of some information about who we are, the PRC Program of Toronto, we are basically knowledge to practice resource funded by the Ministry of Health and Long-Term Care. We support long-term care homes in building capacity around dementia, mental illness, behavior management, assessment, and even team processes. And we also support community support agencies in the Toronto area as well. Something to know about the PRC Psychogeriatric Resource Consultants is that we are available to all long-term care homes across the province. So at this point, we want to ask you, learn a little bit about what's going on in your homes. We're going to toggle a poll here and ask, have you had resources redeployed into your home? Or are you currently being supported by redeployed staff? Okay, so the numbers are interesting. We're having 59% of participants that say no, and 41% that said yes. So thank you for answering the question. Some things that we should recognize is that this pandemic has had quite an impact on long-term care, and we need to acknowledge the impact it's had, not only just for the residents, but the teams caring for the residents, and how much it's affected frontline staff in long-term care. The impact of this pandemic on frontline staff would also impact how frontline staff might even welcome new people coming into the facility and support the redeployed staff. We want to work with frontline teams to recognize, by taking the time to welcome and orient redeployed team members, this can ensure day-to-day functioning of the unit can be supported seamlessly by the redeployed teams. We need to also consider ways for leadership to consistently support open communication and sharing of vital information with redeployed team members, whether this information is shared verbally or written. The thing is, when we do offer clear communication to team members, it can be reassuring and it can actually reduce anxiety for the redeployed teams, but it can also reduce anxiety for the frontline long-term care teams as well. Some things to take into consideration is that long-term care teams are a wealth of experience. They are a wealth of knowledge. They know their residents very well. They know triggers for behaviors. They know the behavior care plans. They know strategies that work with people. They just know their residents. And the long-term frontline teams are people that redeployed team members need to be connected with, and information should be shared from the frontline team members to successfully care for the residents by the redeployed team members. So long-term care homes should consider how to best share this information, like behavior care plans. What access would redeployed team members have to these care plans? The thing is, we know that most long-term care homes have moved towards the electronic charts, such as point-click care, and this technology may be very limited, and the redeployed team members may not necessarily have access to the care plans electronically. So how can we make sure that there's paper copies available for redeployed team members to read up on and better know the resident through these care plans, and what are the proper strategies and tips that need to be used to support behavior management? Also, if there's behavior care tip sheets that have been made available by the team in long-term care, this can actually be very helpful as well. These are typically tip sheets that are created by the internal behavior leads if they are available in your home. Other resources that have been made available for redeployed team members are online resources such as covidlearning.ca. There's many different webinar series there and education series that really offer a lot of information for redeployed team members to successfully do certain roles and tasks in the long-term care home. Another resource that is available is through the RGP of Toronto. The PRCs of Toronto, the PRC team, has actually been hosting a series of webinars. One actually just finished 30 minutes ago on different topics around behavior management in long-term care. The good news about these webinars are they are archived on the RGP of Toronto website, so it is accessible afterwards, even if people have missed it. So we do encourage long-term care homes and the management of long-term care homes to let these redeployed team members know that there are these resources available to support their learning. And actually be quite complex because where people are coming from, what skills they have, matching those skills and resources to what's needed in the long-term care home, it can actually be quite complicated. We do have professionals being redeployed from the Canadian Armed Forces, and there's that potential that there'll be people redeployed from the school boards as well. And typically these people do not have any working experience with persons with dementia, let alone the long-term care system. There's also an underlying assumption that team members who are redeployed from the hospital because of healthcare experience, that this redeployment process would be more seamless. However, because of policies, procedures, and goals of care, there can actually be a discrepancy between the long-term care home setting and also the hospital setting. This becomes even more complex when a redeployed professional skill set doesn't necessarily match requirements to complete tasks in long-term care. So some examples can be like, you might have an occupational therapist. Depending on their role in the hospital, they may not be able to provide support with using a Hoyer lift, but there might be an assumption that they can. Also, team composition varies between long-term care homes and also in hospitals. There is a difference. When we think about the team composition, long-term care may not be aware that resources such as activation and social work may not necessarily be available in all hospitals. Hospital teams may not also be oriented as to how resources like social work and activation can be of support in the long-term care setting. When we think about the social work role in a hospital, the focus might be more around discharge planning, whereas in long-term care, the role might be more of providing ongoing support for residents and families. So that is that whole curative focus versus the palliative and restorative focus. You know, when people go into hospital, people go in there for a purpose. They get their assessments, they get treated, and then they get discharged. Whereas long-term care, this is where people live. This is where people stay. This is their home at the end of the day. There's also, we need to take into consideration about behavior management in hospital versus, in comparison to long-term care, is the use of physical and chemical restraints. In hospitals, is a least restraints policy. There's a least restraints policy, but in long-term care, it's a zero restraints policy, zero to least restraints policy, and that is something that is it's legislated, and it's also being very followed up by the Ministry of Health and Long-Term Care. When we're thinking about behavior management in urgent situations, in long-term care, teams do not have access to security. And it's important to note that in long-term care home settings that whenever a code white happens or an urgent situation happens, it is the frontline team that's managing that situation. So it would be really important to orient the redeployed team members to code white policies and procedures. Well, in long-term care, there is a very much a person-centered approach to care. In hospitals, they're moving towards a person-centered approach to care rather than the treat and discharge approach. When it comes to treat and discharge, it really does leave limited time for team members to really get to know the patient in the hospital. Whereas in long-term care, care plans are developed with the philosophy of person-centered care in mind, getting to know the person behind the illness and really developing the therapeutic rapport with the resident. So it's really important for long-term care teams to really share the care plans and the tools for success when it comes to working with residents that may have responsive behaviors. So at this point, I'm going to pass it on to Helly, who's going to talk about the behavior management structure in long-term care.
Thank you. Okay. So one of the other areas we want to spend a bit of time thinking about is behavioral supports in a long-term care setting. In a variety of conversations amongst care providers from different sectors, we have heard about the need to share information on the behavioral support system that has been developed over years that supports our Ontario long-term care homes. Staff may come in and be advised, these are your residents and these are your tasks. But we want to think about how can we support the needs of unique humans who live with cognitive changes. So as the first point highlights, it's helpful for incoming teams to know internal structures exist to support residents with responsive behaviors. So for example, we've listed the internal behavioral lead as well as the behavioral support resource team. Both of these internal resources are key to behavioral management plans and planning. Another established component of behavioral supports to long-term care, of course, are your external care partners. So we've listed here the Geriatric Mental Health Outreach Team, GMOTS, or the Psychogeriatric Outreach Program, the POP teams. We've given some of the different names that are used across the province, recognizing that they sometimes go by different names, but the function tends to be quite similar in that most of these teams would have a psychiatrist that's available for support and consultation to the residents, along with clinical frontline staff who can provide pharmacological and non-pharmacological support as well. And in conversations, what we're hearing is that some of the new players on the scene don't always realize that we have quite a rich support structure in place. So allowing these members, the redeployed teams, to know that there are these resources. Another resource, of course, being the Psychogeriatric Resource Consultation Team. So us, Mario talked about the support that we're able to provide and that we're a parental resource as well as one of the other major players being the BSO Ontario program. Again, we've listed it generally on this slide because depending on which LHIN you're in, the BSO support team might look different. But allowing the redeployed staff and redeployed teams to be aware of the fact that many of these teams exist and do come in and support the residents they may now be working with, and that there's often care plans in place And how can these teams access and really benefit from the knowledge of all the work that these teams have put into place to support residents? Another document I want to make mention of is if your home has actually spent time developing the All About Me tools, this is an opportune time to be using that information to share that with redeployed staff so they can get to know folks a little bit differently in terms of supporting them. Another concept that we've heard about is really thinking about how do we share with the redeployed staff the high-risk situations. So we've heard some examples where redeployed staff aren't quite sure about the level of risk with some of the behaviors they may be encountering. And so looking at how do we share high risk versus low risk situations. I think essentially what we really want to think about is how can we share with redeployed staff that these resources exist, and that oftentimes the behavioral care plans have been weeks and months in the development, and we want to ensure that the redeployed staff can benefit from them as they serve to benefit the residents. So as you look at this slide with the arrows, what I'd like to ask you to do is cast your mind back to the time when you started first to work for your current organization. How did it feel trying to do your best without the support of knowing your environment? Throw in it's a busy environment with lots of busy people. Who do you ask? Well, this one may seem obvious, but we have heard stories of redeployed folks feeling lost in their new space. At one home, the redeployed staff showed up as the long-term care home staff were exhausted after completing a double shift. So things were missed in the extremely limited shift exchange. Other hospital staff have been deployed to different settings and have shared with us that they don't know the computer system, they don't know where to find supplies, not understanding the jargon. So you might notice one of the questions we have on here is which floor is the Pine Tree unit? So recognizing that we do have our own lingo and our own jargon. And I use these examples not to find fault, but to consider what can we learn as we're all trying to figure this out. So one lesson that we're learning is that taking the time to share some of this info really saves time when redeployed staff don't have to search for this information on their own. And finally, another concept that we've heard about is making the most of the redeployed team support. And so recognizing that redeployed team members coming in have a variety of skills and experience in different disciplines. And so one of the thoughts is thinking about, is there a way to try to match skills with service needs? So, in a simplistic way, talking about housekeeping staff who may be redeployed can support infection control with the cleanliness of the unit. But in thinking about the school boards potentially redeploying staff, one of the potential backgrounds that I know could be redeployed are speech language pathologists. So they may be better suited and feel more comfortable in providing support around feeding, thinking about OTs and looking at what skill sets they might be able to provide in terms of supporting residents who might need help with getting dressed. So we know it's not always possible, but thinking about this as a possibility to try and maximize the skill sets that people are bringing into the home. It also may help with some of the ambiguity around scope of practice. So we've identified in point number 3 here that regulated team members might be redeployed into a role outside of the regular scope of practice. However, they still have a responsibility to abide by their respective college standards. So this has the potential to lead to some gray areas. Another gray area that we've heard about a few times is the confusion that remains around IPAC procedures. So looking at how the home and hospital can really collaborate to closely support teams in using consistent IPAC protocols. Thinking about how IPAC support can bridge the connection between redeployed team members and the long-term care home team. So another example that we heard was a redeployed staff actually saw one of the long-term care home staff at the end of the shift not degown, put on their coat, and leave the long-term care home to go home. So there does still seem to be some confusion around, what are the protocols that staff should be employing. So having some form of clear and regular communication about the updated protocols, recognizing it feels like things seem to change so quickly, but having very clear expectations on what the home's protocols are. And then the last idea we want to share was looking at ways to support frontline staff in the long-term care, taking initiative in orienting redeployed staff. And the reason we bring this one up as well is as PRCs going into long-term care and supporting long-term care, we have experienced frontline staff who sometimes may be unclear about their role or their ability to take a level of authority in initiating changes under normal circumstances. So under the current circumstances, it probably would be helpful and supportive to the long-term care home staff to really feel like they're empowered to be able to be part of that orientation, the communication, and the direction of supporting redeployed staff. Okay, so we are pretty much at the end of what we want to share with you. And we're going to be moving on to some Q&A time. But as resource consultants, we're always looking to better our understanding and hear more about innovative ideas. So we also have thrown these two questions out for you. But we'll open the floor now to some discussion and questions, and we'd be curious to hear what your thoughts are on how we can best support redeployed folks.